they have picked up another. We picked up another virus. So altogether, totally 5 types of viruses. So let me go into the epidemiology of dengue fever. So dengue fever is spread by Aedes aegypti mosquito. It is prevalent in urban area. The breeding place for that mosquito is a small containers which has stagnant water. So dengue generally was epidemic in European countries during 20th century. Now slowly it has become endemic in tropical Asian countries. Generally, dengue fever occurs in urban areas rather than village areas because the population is crowded. Young children and young adults, they are affected more. Grown-up adults, they are mostly immune to all 4 types of viruses. So dengue commonly affects younger children and young adults. And sometimes the dengue fever appears like a contagious disease because it forms in small clusters. Secondary cases occurs in short interval. So it might look like a contagious infection. So I'll mention about the dengue hemorrhagic fever. How does it occur? So mostly primary infection is a primary dengue. The very first infection with the one type of virus, it is called primary. That goes off like an ordinary viral infection. When the same person has an infection with another type of virus after some time, they develop severe hemorrhagic fever. Even that secondary type of dengue, most of them will have very mild illness. Only very few people will have mortality. So one interesting finding they picked up is that severe form of dengue fever is very rare in African people. They have the infection, but they don't develop the complication like severe dengue or dengue hemorrhagic fever. Probably some they have a genetic resistance or something. We are not aware like. So then coming to the pathogenesis, very important to understand the management of severe dengue fever. You should know the pathogenesis. So main problem with the dengue fever is capillary leak. Capillary leak, how does it occur? Whenever the viral load is low, when the viremia is severe, there will be activation of complement and release of lot of cytokines. Now we call it a cytokine storm. So the activated complement, the released cytokines, and the viral protein that is called NS1, non-structural protein 1. These 3 factors act together. They interact with the endothelium of the capillary and platelets, and they interact with the clotting factors. Thereby, it causes the capillary leak. So this capillary leak is responsible for hypotension, hemoconcentration, shock, hypoalbuminemia, and hyponatremia. All this kind of problem occurs because of the capillary leak. Regarding the pathogenesis of bleeding, it's not completely understood. Mild DIC, liver damage, and low platelet. They act synergistically and cause bleeding. One more factor, iatrogenic. If we use NSAID or aspirin, that may contribute or aggravate the bleeding. It's again another important learning point. So I will repeat, the pathogenesis capillary leak is very important. If the leak happens slowly, then we can manage. The child will survive in a nice way. If the capillary leak is massive and sudden, it is very difficult to manage. So, same way. Bleeding, most of the time we don't see bleeding. If at all, it will be very minor. We don't see major bleeding. But one point to notice, please avoid steroids and non-steroidal anti-inflammatory drugs for viral fever. Okay, then we'll come to I'll briefly mention about the clinical feature. So this graph shows initial febrile period that lasts for about 5 to 7 days. Once the fever subsides, we have our critical time, which is about 1.5 to 2 days it will last. After that, it's called recovery phase. So during febrile illness, the child will have fever like any other viral fever. They'll have pharyngitis. They can have body pain. They can have lymphadenopathy. Then they can have a rash, generalized rash. Some amount of dehydration might be there. So fourth day or fifth day, everything will subside. So I have some interruptions. So once the febrile phase is over, the child will enter into the critical phase. As I said, after 5 days or 7 days. So during that period, in a well child, suddenly the child will develop shock, low BP, cold, clammy skin, abdominal distension, breathing difficulty. With that, they will present all of a sudden. So once the critical phase is treated properly, they will enter into recovery phase. So during recovery phase, all the leaked fluid will come back into the circulation. So they'll have a lot of diuresis. They'll have electrolyte disturbance. Sometimes we people would have treated the child in an enthusiastic way. Volume overload will be there. They can land up in cardiac failure and pulmonary edema. Regarding the clinical feature, I forgot to mention retroorbital pain, which is more diagnostic. And they can have biphasic fever. And sometimes the viral fever is preceded by severe back pain. These are all characteristic findings during febrile illness. So these are the clinical pictures showing that capillary leak. These are the rashes. So body flama.
Hello?
So it's not audible now.
Yeah, that's why I'm asking. Sashi Kumar?
Hello.
Yeah.
So இப்போ எவ்வளவு நேரமா பிரேக் ஆயிருக்கு?
இப்ப 2 ஸ்லைடா பிரேக் ஆயிருக்கு. Hello.
Now audible இருந்ததா?
Am I audible?
Yeah, you are audible.
Yes, that skin
Speaker, please mute others also because some disturbance is going on.
ஆமா, எனக்கு இருக்கு.
Sashi Kumar, please mute others except the speaker. Sashi Kumar? Yeah, now the disturbance is gone. Yeah, please, please go ahead.
Yeah, I'll present. Yeah. So regarding the clinical feature, the child will have febrile phase and critical phase and recovery phase. So for practical purpose, we classify dengue into severe and non-severe. In non-severe dengue, we have fever without any warning signs that may be diagnosed or it goes undiagnosed. Another category is dengue with mild warning signs like epigastric tenderness, minimal liver enlargement. Sometimes they'll have severe classical warning signs. So if the child presents with warning signs, it needs admission and close monitoring. Let me tell you the warning signs. Severe epigastric tenderness, liver enlargement more than 2 centimeters, evidence of capillary leak, that is fluid accumulation in the abdomen or in the pleural cavity, sometimes periorbital edema, and restlessness. Child will be restless because of dehydration and tissue hypoxia. So these are the classical warning signs. If the child presents with warning signs, you have to admit the child for treatment as well as management. So in severe dengue, how does it present? Most of the time they present with shock. The shock will be either compensated or uncompensated frank shock with cold peripheries and cyanosis they'll present. Or else, sometimes they'll present with abdominal distension and respiratory distress because of the fluid leak. Significant quantity of fluid will accumulate in both the pleural space. Rarely it can present with bleeding, either minor or major. Sometimes, very rarely, organ involvement will be there in the form of hepatitis. Hepatitis will present with elevated enzymes. Sometimes, rarely, they can have altered sensorium. I haven't seen a child with CNS involvement yet to see. So, how will you diagnose dengue? Whenever there is an epidemic is going on, it is easy. Based on the index case, we can suspect. As I said, clinical features, retroorbital pain, a rash, sometimes classical rash will be there, or bone pain and myalgia. Those will be clinical clues. If you do serology, you can pick up. What are the laboratory investigations suggested for a child with dengue fever? Hematocrit, that is packed cell volume, that reflects the hemoconcentration. Then PT, APTT, and platelet level. In severe cases, you have to do liver function tests also. So in liver function tests, the enzymes will be elevated because of the organ involvement. One more learning point in pediatric age group is paracetamol poisoning. Because all those anxious parents, they'll give too much of paracetamol during febrile phase. I've seen few cases where we thought it is severe dengue turned out to be paracetamol poisoning. So just keep it in mind. If the liver enzymes are unusually elevated, the child is not that sick, think about paracetamol poisoning. It can happen in any dengue fever. Then if the shock goes uncorrected, a renal function test has to be done. We are doing ultrasound to assess the severity of the dengue. And ultrasound will give you evidence for capillary leak. That is, capillary leak is there or not. So you'll have free fluid in the abdomen, free fluid in the pleural cavity, more on the right side. And gallbladder will be thickened, and around the gallbladder you'll have a collection. This gallbladder sign is again reflects the severity of capillary leak. And of course, serology, IgG and IgM can be done. Viral studies we don't do. Sometimes co-infections can happen like malaria and UTI. So you have to investigate for that also. If there is any evidence of multi-organ dysfunction, please do serum ammonia and lactate level. See, lactate level will indicate the level of peripheral perfusion. ECG, myocardial involvement will be there. Sometimes ST changes are there. And clinically, we have picked up a lot of children with bradycardia, relative bradycardia. The pulse rate goes up to 30, 40 also. And echo, sometimes it can pick up cardiac failure features as well as pericardial effusion. So then how will you manage the child with dengue fever? So any febrile child where NS antigen is positive, child is doing well, and you examine the child on OP basis and look for the warning signs. If nothing is there, Every day you can ask them to report to you. Then the treatment suggested for OP patient is giving a lot of ORS to maintain the BP. If the child has any of the warning signs, like I told you earlier, epigastric tenderness, severe vomiting, liver enlargement, evidence of fluid leak like abdominal distension and difficulty in breathing, any bleeding or shock, so you have to admit. So how to manage? What are the problems we face in dengue? Commonly, we manage only shock because most of the time they present with shock, either compensated or uncompensated. And another problem we face in dengue children, once they recover, during recovery phase, whatever the fluid leak will come back into the circulation. And we would have given a lot of IV fluids without any warranty, or unwarrantedly, we would have given a lot of fluids. So those things can cause respiratory distress, which can be managed in a semi-intensive care by giving oxygen, rarely diuretics. And regarding other complications like bleeding, which I haven't managed actually, generally I refer them to the tertiary care center. And another complication of dengue is the abdominal compartment syndrome. This is because of fluid accumulation, tense ascites. Then rarely encephalopathy, yet to see a case. Then renal failure. So all these problems you have to manage. So let me discuss in detail about the shock management, which is very practical, useful for day-to-day practice. All the general practitioners or anybody who is involved in treating dengue cases, they should know the basic. So regarding the management of shock, whenever you see a child with shock, well, check the BP first. If the BP is normal, that is systolic BP is maintained, but diastolic BP will be high because of the vasoconstriction. The pulse pressure will be narrow instead of 40. For example, 120, 100. So it is an early compensated shock. Do not miss. So checking the BP carefully is very important. So compensated shock, you give oxygen. Any child with shock, give oxygen first. Then load the normal saline, roughly about 15 to 20 ml per kg over a period of 1 hour. Then you recheck the patient's pulse volume and capillary refill. If everything has improved, slowly you taper the IV fluid. After 1 hour, still the pulse is weak, pulse pressure is narrow. Give another bolus of 20 ml per kg over a period of 1 hour. Again, you have to assess. If the child is not improving, then third dose, we suggest colloids. Saline is a crystalloid that will be in the circulation for shorter time only. Colloids exert a lot of positive pressure, so it increases the BP in a sustained way. So third dose should be a colloid. Even if the baby is not improving, you can start them on inotropes and refer the baby to a higher center. And this is the chart generally. In any compensated shock, start the child on 20 ml per kg of normal saline for a period of 1 hour. If the improvement is there, reduce the dose over 110 ml per kg for 2 hours, then 7 ml per kg for 2 to 4 hours, then 5 ml per kg for 4 hours. Slowly you can taper. Then you can change over to oral fluids also. If there is no improvement, you can repeat the clinically, you can assess, or you can do a PCV, hematocrit. If it is still increased, you can give another bonus dose of normal saline, that is 20 ml per kg over 1 hour. Again, you assess after the second dose. Improvement is there, reduce the crystalloids slowly. So if there is no improvement, then you can give colloid. If the hematocrit is falling drastically, it means there is a silent bleeding in the GI. So think about giving blood, not platelets. Blood transfusion is indicated if there is a sudden drop in hematocrit or obvious bleeding in the GI tract. Regarding the hypotensive shock, put the child on oxygen. have to give normal saline. Please listen, 20 ml per kg normal saline. Suppose 20 kg baby means 400 ml normal saline within 15 minutes. So any hypotensive shock where the peripheries are cold and clammy, chill, and capillary refill time, CRT is more than 2 seconds. Please start them on bolus that has to be given rapidly. Preferably put a 3-way and use a 20 ml syringe. Just pull and push. Within 15 minutes, you have to push the fluids. So if the child presents with a hypotensive shock, take the baseline investigations, and hematocrit has to be repeated after every bolus. Okay, for that purpose, do the baseline investigations first. Then after a bolus, the child is not improving, the pulse is not normal, then please give colloid 20 ml per kg. Colloid, we have a lot of preparations in the market, gelatin-based or starch-based. They can give you some allergy and anaphylaxis. Better be careful while using these colloids. So second dose of bolus of colloid has to be given within 30 minutes to 1 hour. Then check the hematocrit. IV fluids. If there is no improvement, third dose of bolus can be given over 1 hour. Okay. This is the flow chart for a hypotensive shock. So start an baseline investigation before fluid resuscitation. Initial bolus, as I said, should be given within 15 minutes. If there is no improvement, hematocrit has to be checked. Second bolus of colloid or crystallite can be given over 30 minutes to 1 hour. If there is no improvement, check the hematocrit again. You can give third bolus of colloid or crystallite. If there is an improvement, slowly you can taper the fluids using normal saline, like 5 to 7 ml per kg over 2 hours, then 3 to 5 ml per kg over 2 to 4 hours. Gradually, you can reduce. So in any severe shock, giving oxygen is very important. And regarding fluid overload, you can use some rarely diuretics. Monitor the electrolytes carefully because electrolyte imbalance will be there. If there is severe cardiac failure, you can digitalize. Regarding bleeding, whenever there is bleeding, what is advisable is a fresh whole blood, not platelet concentrate, not clotting factors. Please give only fresh blood because that has a lot of clotting factors as well as fresh blood is advisable. The 2-3 DPG level will be high in a fresh blood. That helps in tissue anoxia. Then regarding the abdominal compartment syndrome, it again needs intervention in a higher center. Encephalopathy, obviously supportive measure. Then renal failure, renal replacement therapy can be given. Thank you. Hello.
Sir, all of us are with you.
Wow. I think I finished it quickly, sharply.
One good thing is in that we can pull in more questions. Interactive, it will be nice.
Yeah, let it be. There'll be more pleasure of like. It will be more pleasing.
Fantastic, sir. It was very good.
So there was a break in between. If I miss something, please remind me. I can rush through it slowly also, quickly.
That was the...
So that pathophysiology, I feel it is very important. That is the capillary leak and bleeding. Please understand. The capillary leak is because of this so many interactions, cytokines, complement, and the viral particles. The leak can occur suddenly also, slowly also. If it happens suddenly, the child will collapse like anything. In front of it will collapse. Bleeding rarely occurs. If you fail to recognize the shock and if you fail to appropriately treat the shock, they'll end up in bleeding. Uncorrected shock will damage the liver. That will attribute to the bleeding problem. And as we practice, we can avoid NSAID. That has one role for bleeding.
Kripa sir has lifted his hand.
Yeah, please, sir.
Sir, sir, how accurate are the CAR tests, dengue CAR tests?
So it's fairly reliable. NS1 antigen card, it's fairly reliable. But most of the time, we don't do it actually. Whenever there is an epidemic, the case definition is fever for more than 2 days, more than 4 days, and low platelet. Take it as dengue and treat. Probably you need not confirm it. Hardly I do.
Okay. Thank you. Thank you.
Thank you. When there's a diagnostic confusion, like if it is mimics malaria or something, then we can do. Sometimes malaria can present like this, no high fever and low platelets. So otherwise, routinely we don't do. And of course, we are doing ultrasound that gives an evidence, no, for dengue. Am I clear?
Yeah, got it. Thank you, sir.
Thank you.
One question, Dr. Ganeshan.
Yes, sir.
Sir, you have to unmute. I'll unmute you, or you have to unmute yourself.
Hello.
Okay.
Yeah.
Yes,
Am I
Dr.
audible?
Shanmugam. Yeah, you're audible, sir. Go ahead.
Yes. Normally, the ELISA test, they report 3 results. NS1 one, adukapra one, N1. Do you think the NS1 alone is enough to?
Yes, sir. NS1 alone is enough to.
And the other 2 tests are negative.
Yeah, that is enough, sir. In early phase,
what is the significance of the other 2 tests?
Yeah, that helps to differentiate between primary infection and a secondary infection. If both IgM and IgG are positive, the child has a secondary infection where we can anticipate problems like severe dengue fever, shock, and bleeding. If IgG is negative and IgM is positive with NS1 positivity, it indicates primary infection. So to differentiate between a primary and secondary dengue, you need all these parameters. Am I clear, sir?
Yes, you are clear.
Yes, sir. Sometimes earlier pannidrom. Second day of fever ellarum pannidranga. No need, like 4th day, 5th day pannaka IgM positive avrum.
Does it give lifelong immunity?
Yes, sir, of course. That is the reason young children below 1 year, they don't suffer. They have very minimal symptoms because it's a primary infection. Grown-up children and young adults, they have severe dengue because viral infection. Most of them, like 10 years old, 12 years old, and teenage adults, they have secondary dengue. They suffer a lot. Again, 40 years and above, they have developed full immunity for all 4 types of viruses. So they do not have developed severe dengue, or they don't develop at all because they would have faced all the 4 viruses. So the immunity is lifelong, apparently. That the other cross. Yes, sir. Yes, sir.
How long can you wait for the platelets to come up? Can you wait till 10,000? 10,000 or 20,000?
Personal view, platelet transfusion is totally useless. Up to 6,000 you can wait. Platelet transfusion doesn't help at all. The public psychology the fear psycho transfusion கொடுக்கிறோம். So I waited till 6,000. Sometimes teenage girls with periods time will give because they love bleeding, no uncontrolled bleeding. Sometimes we transfuse, but whatever said and done, platelet transfusions are totally useless. கடல்ல கரைச்ச பெருங்காயம் மாதிரி நீங்க லிட்டர் கொடுத்தாலும் அது பத்தாது.
One of my relative girl, she passed away when she was in periods.
Oh, that's why I suggested you. Like girls only sometimes I give because we are also scared. Like, otherwise, below 10 we can wait. Yes, sir.
Is there a role for steroids?
Absolutely no role. Please avoid steroids. It does more harm. never ever give steroids. Although WHO protocol, even in Sri Lanka, there are extensive studies. All these Asian countries, Singapore and Vietnam, other areas, they don't use steroids at all. Sometimes in our setup, an adult physician, they use, but personally, I haven't used the steroids for children. In the worst shock case, we manage it only with fluids. Steroid doesn't have role, sir.
Does the clinical test, which goes by the name of Hess test, apply this BP cuff, inflate it to
Yes, sir.
150, wait
very
for
good,
10
sir.
minutes?
Beautiful, beautiful. The tourniquet test is diagnostic. It can be used in the bedside way. Where the resources are very poor, you can use that. Tourniquet test positive means low platelet. For remote village, PCV panna mudiyala, fever, tourniquet test pannidala. It's one of the diagnostic aid. Definitely, you can rely on this. Highly recommended, sir.
Okay, very good.
Thanks for
Nice
asking
one.
those questions, sir. Nice
Yeah,
questions.
tourniquet. I forgot to mention actually. I'm sorry, I forgot.
Yeah, எல்லாத்தையும் சொல்லக்கூடாதுங்க சார். அப்பதான் வந்து questions நம்ம instigate பண்ண முடியும். Sir, Dr. Shanmu Sundaram has risen his hand. Sir, நீங்க unmute பண்ணிட்டு நீங்க பேசலாம் sir.
Good evening, sir. I'm Dr. Shanmu Sundaram.
Yes, sir. Nice
Is there any other viral disease mimic like dengue? Sometimes when we are focusing endemic or epidemic times, seasonal times, all the fever cases we are treating as dengue.
Yeah.
Is there any other disease, viral disease mimic like dengue, sir?
All this rickettsial infection. Sometimes scrub typhus. Sometimes malaria. They mimic. This illame, like I label it as non-dengue viral infection. That's all. Because at the serology, everything will be negative. They have unexplained drop in platelet without any clinical complication. They recover smoothly. Where the investigation will be negative. Serology will be negative. Okay. Ultrasound will be negative. Only thing is fever platelets. So you can treat as dengue-like. You can label it, no problem. Officially, you can label it dengue-like illness. Because it's your clinical diagnosis. Nothing wrong with it.
Thank you, sir. Thank you, sir.
Thank you. Welcome. Any other question?
There's a very good response. 32 people have enrolled.
Nice. One more point I would like to enlighten. During the febrile illness, please do not administer IV fluids. I don't know, because of parenteral pressure, sometimes we admit. So better to give only ORS, oral rehydration solution. Nama over into fluids koduthamnaka critical phase appa we face a lot of problems like fluid overload and other things. So as long as baby is taking orally, please give ORS or any salted drink. No problem, you can manage in outpatient way. When the patient develops proper low BP, then appropriate IV fluids has to be given. So this avoids fluid overload so that the recovery phase will be very smooth. And as I said earlier, paracetamol poisoning I have to consider. Because parents, they keep giving paracetamol for every 2 to 3 hours I've seen. They'll end up in paracetamol poisoning because that is treatable now. You can administer L-acetylcysteine. That you have to keep it in mind. So that's why routinely we do LFT also for all the patients. Look into enzyme levels. Yes,
is it true that this mosquito is a daytime mosquito, dengue?
Yes, sir.
Is it correct?
Yeah, daytime, and it doesn't fly. Yeah, it doesn't fly. Yeah, you're right. And it doesn't fly too much. And the flight distance on the less than a kilometer, they say. Gumbala cases around looks apparently contagious infection. Mosquito borne maritonadu. Is a preventive point of view, it's very important.
There are a lot of mosquitoes in my garden. I used to get them and get them under a big lens and found that one mosquito, which the tail part of it is upside.
Okay.
Upturned. Then another mosquito, which is multicolored,
Okay.
Right? Whose body is straight, horizontal.
Yeah. Probably entomologist will
I think I
tell.
will have to ask this question to an entomologist.
Yeah, you're right, sir. So we have to read in depth. Actually, you're right, sir. So behavior of the mosquitoes you have to learn. Then we can take the preventive measure. In prevention of dengue also, I didn't cover the regarding the vaccine. Vaccine is under development, and probably it will take another few years. The problem with the vaccine one there, it gives
Yes,
a
come on,
partial
come in.
protection. So that partial protection is dangerous because partially protected or incomplete antibodies level, if the person has and if he is exposed to subsequently to another virus, they land up in trouble. So that is the stumbling block in developing a appropriate vaccine. Otherwise, you have to manage all this SPM point of view, remove all water containing breeding places, larvicidal you can spray, and personal mosquito barriers and creams repellents you can apply. So that's how you can prevent.
So to focus on that vaccine part, you suggest vaccination for all age groups, sir?
No. We need a safer vaccine.
Safer vaccine, okay.
The vaccine research like stumbling block ஒரு டோஸ் கொடுத்துருக்கோம் சுமாரா ஆன்டிபாடிஸ் லெவல் டைட்டர் வந்துடும். If they are exposed to real virus, they'll end up in trouble. They develop severe reactions and severe dengue.
Is a safe vaccine available now?
No, sir, it's in a developing stage. GSK and Pasteur, both the companies are in the race. Probably in another 2 years it will develop. Yes, sir. Panipan.
Yeah, what is question number 1? What is the advice you give for the children during the dengue fever? Question number 2, does it give a lifelong immunity? Yeah.
Yes. So adequate rest and fluids and paracetamol. These are the things I advise them. And that it gives lifelong immunity.
Okay.
But we get 2 or 3 episodes because we have 5 serotypes.
Because usually the common people used to say, patients, that juice and grape.
Very light. Don't believe. See, that platelet part I didn't discuss at all. Low platelet doesn't have any problem.
Okay.
So, nariya samaya platelet low agadunaka, you look into the child because he's leaking. Capillary leak is there. That is the meaning it conveys. And the end result on the hematocrit that keeps on rising. 36 cutoff, it might touch 40, 44. So
do you mean to say that papaya juice is totally useless?
You, sir, don't believe, sir. Don't believe.
What is the abdominal compartment syndrome? In which case, what is the management?
Decompression. More of theoretical knowledge, I haven't seen. நல்ல டென்ஸ் ascites இருக்குங்க. ஸோ வீனஸ் ரிட்டர்ன் குறைஞ்சிரும். பவல் இஸ்கீமியா, இது 2 தான் ப்ராப்ளம். ஸோ அகைன் they'll go for shock. வீனஸ் ரிட்டர்ன் குறைஞ்சிறதுனால. ஸோ அதை வந்து டீகம்ப்ரெஸ் பண்ணுறது ஸ்லோவாக பண்ணணும். இதெல்லாம் மோர் ஆஃப் தியரி. I haven't managed. But on the first episode, Chennai, they have seen people. I mean, child trust, they have a lot of experience with the abdominal compartment syndrome. Namandalu severe partla. Of course, we suffered 2017. We lost few of the children also.
Which is one criteria based on which you can predict severity. Platelet count mattuma, anything else?
I feel.
In other words, can you culture this the virus?
No need, sir. No need. Viral diagnostic only serology is enough. PCR can be done. This is not for epidemiological purpose, what type of virus is going on. And the data collection, not for our day-to-day OP patient management, that is not warranted. And regarding the severity, I feel if the patient presents with a severe chillness right at the time of presentation, you can expect a severe dengue. Or else, if you are correcting In the hospital, he develops another episode. Then it's a nightmare. Then age group.
Chill body
Yes.
means peripheral failure.
Yes, sir. Yes, sir. Nalla chilla irukkum, ice madri irukkum. You can feel it actually. You should feel once. Bayama irukkum. Nalla chilla irukkum.
Dr. Jay Krishnan, he's
Yes,
raised
sir.
his hand. Please go ahead, sir.
Yes, sir.
Sir,
Yes, sir.
JK, sir. Sir, we know
Yes.
dengue is symptomized by high fever, low platelet count, and chills. All right. How about, are there any cases of asymptomatic or very mild symptomatic dengue which can fastly turn into a more severe one? And what are the long-term effects of side effects, if any, of dengue?
Nothing, sir. Long-term sequence very rare, very rare. They can have some depression, myalgia, but it's very, very rare long-term. Most of the fevers goes undiagnosed. Because epidemiology, they say per annum 40 crore infections are happening, but only 10 crore people are symptomatic. So it's like a tip of an iceberg. For a mild viral fever, like a 1-year-old child for 2 days, 3 days fever, like any other fever. Even we are not aware, like goes undiagnosed like any other viral fever. And of course, you have long-term immunity. Yes.
No, carry on.
Yes, sir.
Fine, that's it, sir.
So another interesting scenario occurs in younger children. Sir. Since you have raised this question, below 1 year sometime, the mother had dengue already. She would have passed the antibodies through the placenta into the young infant, like 6 months old child. If the 6 month old child get a primary infection, it's more or like a secondary infection. They'll have a severe infection, severe disease, or severe dengue fever. That's a special situation below 1 year. The mother can transmit antibodies. So a primary dengue will mimic like a secondary dengue. So it will be severe. Am I clear?
Yes.
Yes, sir. Any more question?
நம்ம ஊர்ல Zika virus வந்திருக்கா? Zika.
Not reported, sir. It's in Kerala.
In Kerala.
Kerala, yeah, it's been reported.
Yeah, just for everybody's interest, sir.
Yeah.
We had just about a month back, we had a crisis from a doctor.
Yeah.
A child was she came with shock and treated with IV fluids, and
Okay.
adukaprom they were not willing for admission, so they took her to GH. GH apparently the patient says that some doctors had she had some shortness of breath. So they said it seems that if we rush fluids, fast, bolus கொடுத்தா இந்த மாதிரி வந்திருக்கும் அப்படின்னு சொல்லி ஒரு வார்த்தை சொல்லிட்டாங்க. So they caught hold of that, and they were the first primary doctor புடிச்சு they were so
okay, that's why I was telling you, before admission, please avoid unnecessary fluids as an outpatient. But whenever there is a shock, nothing wrong in rushing the fluid. That is a way. That's a document actually. You can tell them. See, the child is very cold peripheral. I have to push the fluids. So probably miscommunication in the GH also. Some inexperienced person would have given a wrong information.
So request to doctors over here. இங்க இருக்க டாக்டர்ஸ்க்கு அண்ட் பீப்புள் அவங்களோட ஃப்ரெண்ட்ஸ் எல்லாத்துக்கும் இந்த மாதிரி நம்ம we have to be very careful when we are communicating with patients, especially about the other doctor and things, because it will lead to a lot of problems. We had to go back and forth No, it was a major issue for 1 month.
Ventilate பண்ண வேண்டிய
Distress
அவசியம்
வந்துருச்சுன்னா
ஏற்படுமா
it's very
சில
difficult.
கேசஸ்க்கு?
Yes, sir.
Ventilator.
Yes, sir. Beautiful. Yes, sir. So we are giving non-invasive ventilation. Actually, on the recovery phase, all the children, they develop respiratory distress. They come with distress also because already there is leak. So we manage with high frequency ventilation, what is the HFNC, nasal cannula. So that helps in relieving the distress. We don't intubate, better not to intubate because low platelets, it will be very difficult to intubate also. So we can manage with NIV, non-invasive ventilation with mild sedation for 24 to 48 hours. They'll come out of it. Once the diuresis occurs, they'll recover ultimately. So we don't go for invasive ventilation. This is not really severe. Like as I said, abdominal compartment syndrome, severe massive pleural effusion. There you have to go for invasive ventilation. You need a good team to manage the children.
Having accepted that steroids are
Yeah.
useless,
Yeah.
some people say steroid increases the platelet count. Is it true?
No, sir. No scientific evidence. You can go through the literature also. You can Google, no problem. It does more harm. Sila period argument on the adult level, the what is that? Cytokine storm.
Cytokine storm.
We are using.
Steroids.
So we are using. Justify
Hydrocortisone IV போடுறாங்க.
Yeah, it's not an accepted practice. Even WHO doesn't recommend. Even Western literature, they've done a lot of studies. Steroids does more harm. It's been proven. Certain anecdotal reports are there. They are because it is their personal view. I don't know. Any viral infection on the steroids is always a double-edged weapon. It might aggravate the viremia. If the viral load is there, you'll develop all the complications. The pathogenesis I mentioned, no? So they'll end up in severe dengue fever. So steroid does more harm. This is my view.
Is there some sort of a seasonal incidence of dengue? It comes in
Yes,
March, April?
Yeah.
Or
it's a cyclical, like once in 4 years we get. 2017 அப்புறம் 2021 கொஞ்சம் வந்துச்சு. அப்புறம் ஸ்லோவா லைக் எண்டமிக் ஆயிடும். கான்ஸ்டன்டா கேசஸ் வேற இருக்கும். பட் எபிடமிக் வந்து இது வரைக்கும் நாங்க நோட் பண்ணது வந்து once in 4 years சைக்கிள்ல வருது.
Is there any preferred months? March, April?
Yeah, common. March, April. You're right.
Do you have a dengue case in your hospital now?
Yes, sir. Today I discharged a child. 2 cases right now.
Good.